Welcome to another episode of the Wealthy Podcast. I'm Shauna Nyros, your host, and today we are talking to a Kelowna General Hospital physician that is really special to me. We'll share all about why that is. Dr. Brenda Farnquist is a radiologist. She specializes in medical imaging, and today we're going to talk all about breast cancer screening, prostate cancer screening. It's certainly going to be an episode that you'll want to listen to if you would like more information about how you can take more proactive measures in your life to ensure your breast and prostate health. Today, I'm really excited to welcome Dr. Brenda Farnquist to the Wealthy Podcast. Dr. Farnquist is the president of the BC Radiological Society. She's active on the University of British Columbia Radiology Wellness and Equity, Diversity, and Inclusion Committee, and she also happens to be one of our favorite radiologists here at Kelowna General Hospital. We're going to jump right in with Brenda today and have a really great conversation about all things radiology. So welcome to the podcast, Brenda.
Thank you.
Is it okay that I call you Brenda?
Of course.
I know sometimes we get very formal, but I feel like I just want to
know each other very well.
We do know each other very well. So I'm going to actually start there. I first met you back in 2019 in one of the most unfortunate circumstances of my life. I found myself needing an ultrasound for a small chocolate chip-sized lump that I had found in my right breast. And so I ended up in your clinic, and after some ultrasounds and then some mammograms and me being totally ignorant and unaware, in walks Dr. Farnquist and delivers me some news that was not fully official until we had a biopsy, but you were the person that first broke the news that there was a possibility that I did have breast cancer. That was a big day. And I'm gonna actually come back to how it is for you when you have to deliver that kind of news to your patients. But what I did want to share with everyone who's listening is I will never forget your compassion and your empathy that day. I was not expecting that news. Oh, see, look at it's already happening. And you sat with me, even though I know you're super busy. And you sat with me and you held my hand because I was all by myself because I didn't think anything was wrong. And you just sat with me until I was ready to leave. So thank you for that.
You're very welcome.
And you will always, I know, I totally remind you every time I see you how much I adore you, but I will never forget that moment. So thank you and welcome. It brings me great joy to welcome you to this podcast. So we like to start with an opening tradition on the Wealthy Podcast, and that is kind of a question. Most of the people that are sitting in that chair are here because you have a passion and an interest for healthcare. Can you maybe roll back and recall and share with us the first moment when healthcare significantly affected your life or that of someone close to you? Kind of when you understood that health is wealth.
That's a really good question because there are a few things that have happened in my life that has brought medicine into my life. One was the diagnosis of my mother's cousin with multiple myeloma. And I was just a child in probably elementary school, and I decided to do my project on that. So I delved into books in this old library in northern Alberta and found out what multiple myeloma was. And then I was totally fascinated with medicine and science. I didn't know what I wanted to do. I didn't know I wanted to be a physician, from that point on, but it did bring me to become a lab tech. So I did that. And then there was another defining moment when I was on call one night and somebody had come in. It was a significant MVA. And I looked at the team, the nurses, the doctors, myself, the x-ray tech and whatnot. And, we played such a significant role. But then I looked at the physician and said, I can do that. So I went back to school and I became a physician. So at a little bit more mature age, but by 30, I knew, I was in medical school by then. And then I thought I was always going to be a hematologist because of my med lab background. I loved, looking at blood cells under a microscope. And so I thought I wanted to treat leukemias, lymphomas, and whatnot. My husband reminded me that I'm a sensitive person, as everybody can see already. And he's like, you're going to have a lot of patients die. Are you sure that's what you want to do? And I looked out and I'm like, yeah, he knows me well. And I looked around at all the subspecialties, the specialists, the family doctors, looked at how happy they were. And I decided to choose a profession, a specialty that I could see that the physicians were happy, and that was radiology. So that's how it brought me there. But it was a little bit of a path.
Interesting.
With multiple limbs on how I actually got here. The tree.
Yeah,
tree of life.
You are so passionate about radiology. It's interesting that that was sort of one of the predetermining factors is who's happy?
Well, what I figured out is I like anatomy. And I first started out with microanatomy, and then I ended up doing kind of like macroanatomy because that's what pathologists and radiologists, we do the same thing on different levels, right? So, and recognizing patterns of disease, recognizing patterns of normal variants. That's what I do. So we can make a big difference in people's lives, whether or not a symptom is because of some worrisome process or not, or can guide treatment.
Yeah, we've done multiple campaigns together, and you have been a huge advocate for the KGH Foundation and the work that we do. Very, very grateful to you for that. But you've been a really strong voice for the role of radiology in so many different areas of healthcare, which, if you haven't had a lot of experience in healthcare or, with disease or injury, that kind of thing, you may not really realize. But I have always said, since learning how important medical imaging is to healthcare on so many levels, that it is the unsung hero.
Traditionally, we're in the basement, right?
Yeah.
The lab and x-ray is in the basement. So we're kind of these specialties that aren't really thought about, but so incredibly important. And we help physicians triage their patients and their conditions. That's what we do. So I just find that a lot of patients, they don't know what a pathologist is neither, right? They don't know what a radiologist typically is unless they've been through the system.
Okay, so let's go there. What is a radiologist? What exactly is this specialty? What is it all about?
So radiologists read and interpret many different imaging modalities. So when you get an x-ray, an ultrasound, an MRI, a CT, sometimes we're using real-time x-rays called fluoroscopy to do procedures and look at real-time functional images. So we look at those. We don't take them. We have technologists do that. That's the medical, radiation technologists. We interpret them. But we also use these modalities to provide image-guided procedures. They can be therapeutic and they can be diagnostic. It's growing so much. It's just exploded in the last 5 to 10 years with what we call non-invasive. There's still a little bit of invasiveness to it, but we can go through different vessels in the body, veins, arteries, even lymphatics. So they can go through, we can work through the bowel. There's different ways that we can do image-guided procedures and functional studies. So it's totally exciting. It's changed medicine. People don't have to be in a hospital now for days and days and days from an open surgical procedure because sometimes the interventional radiologist can do it through a vessel.
Which is incredible.
Yeah.
What, for the average person, what does that mean? When you have to, when somebody is facing a diagnosis, or finds a lump or breaks a leg or, whatever, their first stop generally is radiology.
That's right.
So why is that step so important?
It's important because we have the training to determine what's significant or not. I think that's really what we do. There's a lot of things that we have in our body and a lot of things that are benign, meaning not worrisome, or variants, meaning we're all built our own way. We develop our own way. And sometimes there can be congenital, meaning we were born that way, or processes such as trauma that can result in the tissues and the bones looking that way. And not every physician can interpret that. So that's what we do. That's exactly what we do.
And then, just in general, and we can talk more specifically about some of the specializations that you have, but just in general, once those scans are done, then what happens?
Yeah. So physician will either receive a report or a phone call from us, depending on how urgent the exam is. But it really lets the physician know, the clinician, and often I call them clinicians because it's either a family doctor or a specialist that will determine what happens with the patient thereafter. So whether or not they tell them this is not worrisome at all, we don't need to worry about this, or this is likely benign, we're just going to follow it up, or no, this needs surgical treatment, interventional radiology treatment, or, if it's a cancer, they could either see an oncologist either on the medical or radiation side. So
it really is like the first stop.
Or the cogwheel. I almost call us the cogwheel. We're always turning in the background and patients go on different pathways on those spokes.
Coming back, you're right, it is sort of like the cogwheel because even though most patients will start their journey in medical imaging and radiology, you do come back because it is a huge part of treatment in some cases as well.
Follow-up of treatment to see if somebody's treatment is, they're having a treatment response versus a failure. Those exams are really important to follow. So.
And I will say this, your team is incredibly happy. We work with a lot of the radiologists here at KGH, and they are one of the most supportive and knowledgeable and generous teams that we work with. We're so grateful for them. I want to talk about imaging screening a little bit because I know this is an area that you are very passionate about. So how can regular image screenings in general contribute to early detection and prevention of disease?
So the province has a number of different screening programs, and ones that we take part in, it's colon screening, lung screening, breast screening. They are very important initial studies, particularly to get the baseline, meaning that very first study. And then we do follow-up studies thereafter, and we look for changes. So often we see things that aren't really, the benign things that we find on screening. Sometimes we're able to say this is not worrisome, but sometimes, the clinician or the surgeon may have to do an endoscopy to see, okay, this is a polyp. It's not they do a little biopsy. It's not a worrisome polyp, but it may put a patient on a different type of screening regimen. Breast screening, which I take part in, we tend to look for changes from year to year, or what we call biannual, every second year, depending on which pathway a woman or man is in that screening program, and look for changes because cancer detection can be difficult sometimes. And we look for changes. So those subtle changes, that the trained eye can pick up, that could be early signs of breast cancer. Some breast cancers can show up as a calcification. Sometimes they just look like distortion, or what we call a developing asymmetry, where an area of the breast just starts to change subtly, or they're a big mass, and that's pretty obvious. But it's these other things that are subtle, where the trained eye is really important to find those other breast cancers.
I find it fascinating. And let's talk a little bit more about breast cancer. I've learned a lot about breast cancer in the last 5 years. But I think, the most important statistic for our listeners to understand is that when it comes to breast cancer, about 1 in 8 women are expected to develop breast cancer in their lifetime. And regular screening mammograms are incredibly important. just a stat here that I'd found. Research has shown that a greater than 25% reduction in deaths from breast cancer for people who regularly screen. So it's so important for women to be part of that screening program. So I'm going to kind of start there. Like, what is a mammogram? And what is it what do you use it for to determine?
So a mammogram is a really high resolution X-ray of the breast. The breast is a pendulous structure from our chest wall. It's not actually very easy to image. And many women will attest that we have to put the breast in compression in multiple views, and it's very uncomfortable. And I think that actually does deter a lot of women from getting it done because it is a little bit painful. But the seconds of discomfort are certainly worth, I think, multiple years of life gained if we find a cancer early. And that's the whole goal of screening, is to find these cancers when they're small, they haven't spread, they're localized to the breast, and we know that we can treat them either, surgically, medically, whatever. Usually it's surgically at that point. And then they can go on and live their life. It's life-changing. And the screening program goes from the ages of 50 to 74. Between the ages of 40 and 50 here in BC, a woman can get screened if they have a positive family history. So meaning a first-degree relative, so a mother or a sister, not a grandmother, not an aunt.
Okay, so if you're
mother,
40
sister,
and you have a relative that has
first degree
breast cancer, then you're eligible to start screening at
early.
40. Otherwise, if there's no family history, you start at 50.
And that's the regular screening program.
Okay.
If a woman really wants to get a study done, we can fit them in through the diagnostic program. So they have a palpable abnormality, and that's usually, so it's not screening. There are two. So I should also clarify that. So there's kind of two pathways in breast imaging. So there's a screening pathway where woman has no symptoms at all with regards to her breast. A diagnostic pathway or diagnostic mammogram is for something, so pain, feeling some ropiness or thickness, or, just an even a mobile or solid, palpable, non-movable lump. Those are reasons. Sometimes nipple discharge, even changes in the skin.
I had a pucker.
Yeah,
that's when I started to freak out a little bit, because I could feel something, but my GP was sort of like, meh, things change, we get old, it's kind of there, but there's not, but then I noticed that it was like a puckering, and I learned later, it's interesting because they call it cancer, which is in the zodiac, cancer is a crab, because it like grabs on to the tissue and pulls it. And so that's why you get the pucker.
It changes.
Yeah. Interesting.
So they can be really subtle, because sometimes a breast cancer can be very insidious, and it kind of goes along the framework of the breast but doesn't form a mass. Those ones are really hard to detect, and sometimes it's that kind of thing that we see. So that little bit of distortion we see on a mammogram or an ultrasound, or the skin changes and the puckering that you see physically. So those can be the first signs. Sometimes pain, not very often, but pain can sometimes be the first presenting symptom for a woman as well. So
what you're saying is that there's sort of two different pathways. There's like the screening pathway, which is like, I'm just a 40 or 50-year-old woman and I want to take a proactive approach to my breast health and get a regular screening. And that's every 2 years?
Every 2 years for women between 50 and 74. We screen annually with a person that has a family history with a first-degree relative. And I have to say, so I said mother and sister, but it could be a brother or a dad.
Right.
So it doesn't matter. It's not all. Breast cancers don't just occur in females. They occur in men as well.
I've read
There's
that.
not a screening program for men unless there's a family history of a known mutation. So men can sometimes have the BRCA2 gene, and that predisposes them to breast cancer. So they will often get screened.
Interesting. So just as an aside then, I have both a son and a daughter. Would it be a benefit for my son to also have that BRCA screening?
So this brings up a good discussion. So when women develop breast cancer, if there's a family history, so say your daughter, what we would recommend is that she start getting screened 10 years before the year of your diagnosis.
Okay.
So there are some women that do develop cancer in their 20s and in their 30s. So if they're like their kids, particularly the girls, I guess the females, they should start screening 10 years younger than that.
So in my daughter's case, I was 44. She would start screening at 34.
That's correct. That's correct. The other thing is that BC Cancer has a program called the Hereditary Cancer Program. And people can self-refer, get the family physician to refer them through. And what they do is they sit down with a geneticist and people in that program, and they help them determine what their actual risk of developing cancer, so in this case, breast cancer, would be. They can also set up screening for mutations, so they can do blood tests to look for mutations. Now, we know that there can be hereditary predisposition, not just for the BRCA1 or 2, so the BRCA, which many people have heard of, but there are many others that they have determined, and probably that we haven't determined yet. But you can actually get screening for those markers. And so, and as somebody that's diagnosed at a young age, and particularly under 40, it probably would be useful for them to get screened for that person to actually have the genetic testing to see if they have a gene, if they're positive for that, and that'll help for planning for the family in the future.
Absolutely. Yeah. Oh, that's really good to know. So if we can, we'll pop in information in our notes just so that people that are interested maybe in accessing more information on that. Yeah, it's definitely something I've thought about. I hate that I would have to, lay this on my beautiful, amazing, healthy daughter at some point, and maybe my son. But I think the one thing that I have learned throughout this whole thing is that we have the technology now to be able to find these cancers, as you said, early, and the earlier they find them, the better the prognosis, right? I mean, I don't know. Do you say that breast cancer is curable? Is that a thing?
Absolutely, and more so than ever before.
Okay,
absolutely. The changes in the last 20 years has been transformative in breast cancer treatment, for sure. There are different kinds, and we know that there are some forms that are more aggressive, and those more aggressive forms, like the triple negative that we talk about, often occurs in younger people. So a lot of breast imagers would love to see people screened earlier with perhaps, now mammography has, radiation risk. It's very low, right? Now if we talk about radiation risk, there are risks depending on where you live. We know that in the Okanagan, there are higher level of radon levels in the soil. So we have a natural exposure risk. And we know that over a year, the risk from the mammogram is less than our exposure over a year from just living
here.
Yeah. And there's data online that you can find at the Canadian Association of Radiologists that talk about all of those radiation risks, because I know a lot of women are worried about that. And that actually is one of the things that holds them back sometimes from getting a mammogram. But the message from me is that when you do become eligible to screen, please do it. And it's because some cancers are not palpable, and sometimes they start really early with DCIS. And that's really early cancer that's limited to the ducts. It's called ductal carcinoma in situ. And sometimes we only find that by calcifications. And those calcifications are not found with ultrasound. Sometimes they're not seen. They are not seen on MRI. And they
can't feel them.
You can't feel them. So mammography is really good at picking those up. Now, there are some that talk about us diagnosing cancers early, and that they call them false negatives. But that's not, or false positive, a false positive, because we're finding this DCIS. Well, it's still a cancer, and if it's left long enough,
it will turn into cancer.
It will turn into cancer, and it could be 10 to 20 years. But they say that it's a false positive because we're finding it before, it could ever, won't cause an imminent death at that time. But when I talk to women, I talk to them about this, because sometimes we're biopsying these calcifications to see if they are actually this DCRS or versus fibrocystic change, which are normal changes in the breast that make calcifications. And the majority of women that I biopsy say, no, I want to know.
Of course.
They want to know.
Yeah.
So I don't...
And is the concern that it's too stressful? Like, I've heard that.
Yes.
Like,
yes.
The stress of having to kind of potentially have a diagnosis.
The contrary view, the opposite view is yes, is that we're causing too much anxiety in women. But the ones that come through and they get the biopsy and they know that it's negative.
Yeah.
They can...
Best day ever.
Exactly. And they go on and they continue their screening and we know that those calcifications have been biopsied and they're benign. Whereas a woman that comes in with DCIS, they get it gets surgically removed. They usually get treatment just to that site to make sure that if there's something that we can't see, that it's treated, and then they get surveillance. And yes, it causes a little bit of anxiety whenever any time a woman comes back for a mammogram, there's anxiety. And
there's a term for it. Scanxiety.
Yeah. Scanxiety. And it's
like
an
actual thing. Yeah.
But I think I really want women to just make a plan then. Bring a friend. Do something that helps bring that anxiety down, that it's, and then sometimes you don't get the results right away, right? It goes through the screening program and then you get a letter back or, hopefully not the phone call that you need a call back, but do something that helps you get through that point, whatever it is. And it will get better with time.
And it's so worth it because it could save your life.
Do we have time to talk about callbacks?
Yeah. Well, the one thing I just wanted to say about screening, because this is something I didn't know, and I think it's super helpful and valuable because we know that our health system is pretty strained right now. But you do not need a reason or a referral to participate in the screening program. You can, as long as you meet that criteria of eligibility, you can just call. You might have to wait a little bit, but you don't need to go to your GP and get the referral unless you feel something.
That's right.
Yes.
Yeah, that's right.
Tell me about callbacks.
So callbacks are when, the radiologist is looking at your screen, so say your mammogram, and sees something called an asymmetry or a little bit of distortion. Maybe there's a mass, but we're not sure. So we will call back people when we're sometimes not sure and just want to make sure there's nothing there, or when for sure there's something there and we want to make sure it's nothing worrisome. So callbacks can lead to this scanxiety for sure. And it's one of the major reasons why women actually probably don't come back to the screening program, because I think it's the anxiety. So we know that when somebody has a callback after their screen, sometimes it's a little longer before they come back, or sometimes they don't come back.
Really?
Yeah. But one of the points that I want to make to the listeners is that that's the radiologist kind of doing the job, making sure that it's nothing worrisome. The breasts, when they're placed in the mammogram in compression, sometimes will look a little bit different from time to time. And that's why having, the regular routine scans done with time, we have more and more studies to look back and see that, oh no, that's just the way it was compressed this time. It's a little bit more pliable. It looks a little bit different. But sometimes we bring them back and we do a couple of additional views and the finding totally goes away. There's nothing there. We're happy. You go back to regular screening, and that's very normal. And that's another reason why some of the contrarians are like, oh, it causes too much anxiety, but it's just part of the process and making sure that, things are fine.
And 1 in 8 isn't immaterial.
No, that's significant.
Yeah.
Right? That's really significant amount of women that will have breast cancer. So we're just being really sure. Now, there are some that will get called back, and sometimes there's a cyst in the breast. Sometimes we find benign little masses called fibrinomas. That's a really common thing that we find, and it's an overgrowth of just the supportive tissue. They're benign. We don't really worry about them, but sometimes you need a biopsy to prove that. Those are the more common things, cysts and the fibroadenomas that people get called back from. And then calcifications, to make sure they're not that DCIS, that they're just calcifications from what we call fibrocystic change in the breast, which probably a lot of women have heard about. Sometimes the breasts, they have more proliferative changes. That's what we call it, proliferative changes, where they make cysts. The cysts come and go. Yeah. Sometimes they get calcifications in them. And it's not a worrisome finding, but we do need to check it out. And then sometimes if there's a worrisome finding, then they get called back and we can indicate on that screen how suspicious we are and whether or not we think it's something that really needs a closer, quicker look at. So it brings the woman in quicker for follow-up, and then they may get an image-guided biopsy if need be.
And just to like put this into perspective, I mean, out of all, like what percentage, of women participating in the screening program, like what percentage of those screened would come back eventually as breast cancer?
So callbacks are any between 5 to 10%. And then of those, sometimes it's up to 10% of those will come back, with something significant.
Mm-hmm. Which really isn't, like, that's not a huge number. So as you said, most of the time, there's nothing to be concerned about.
Exactly.
But I don't know. As a woman that has already experienced breast cancer, I would just really highly suggest that screening, although it is stressful and can create a little bit of anxiety, so is breast cancer.
And think about it like taking care of your body.
Totally.
Exercising,
proactive.
eating well,
Yeah.
laughing.
Yeah. And, this podcast is all about creating agency for people to be more participatory in their own health. There's a lot of things that we can do in healthcare, and you do an amazing job of articulating what the technology can really advance for us. But at the same time, like, I think we have a responsibility as human beings, people, to like take some ownership of our health. And this screening is just one way that we can definitely do that.
And this age where a lot of people don't have a family doctor or
Exactly.
a primary care provider, the screening program allows them.
What a blessing.
It allows women and men to take control of their breast health.
Yeah.
Right?
So important. I just want to touch on density, breast density, because I know that this is something, a characteristic of a breast that does have sort of a little bit more of a cause for extra vigilance.
Mm-hmm.
So tell me a little bit about breast.
So breast density is something that we report on in all mammograms now, and it became mandatory in the last 10 years in both Canada and the US. And the reason being is that many women have denser fibroglandular tissue, and it can mask findings. So mammography is still useful for finding calcifications and sometimes that distortion, but when a woman's breast is really dense, it can mask masses. So we've become much more aware of this masking effect, and there's been a lot more investigation and research into it. And we know that if we do supplemental screening, we can find additional cancers. And sometimes as many as 6 in 500 cases, they can find additional cancers from doing supplemental screening. Now, typically that's done with ultrasound or MRI. In BC right now, supplemental screening really isn't that formalized yet. And the problem is because of access to imaging.
Right.
So I think a lot of health authorities and community human clinics would do more of it. But we have such a shortage right now of technologists that we can barely keep up with the diagnostic, meaning workup of findings or, a palpable abnormality, that we don't have the capacity to actually do as many screening handheld ultrasounds as what we would really like.
Okay, so anybody that has children, young adults that are looking for a career, shameless plug.
This is absolutely a plug.
Yeah.
Go into
Do
ultrasound, become an MRT, become a mammographer, and maybe a sonographer.
Because this isn't going away.
It's not going away.
Yeah.
It's not at all. There are some advances in automated breast ultrasound, and so I'm president at the BCRS. We just had our spring meeting, and we were privy to seeing one of those machines, like right on site, and they went over cases, and it can.
Is it like a robot?
It's like a big ultrasound machine, basically, and it has an arm like this, and on the end is a screen. It's the thing that actually gets the images. It's really, it's incredible and can do almost an entire breast, and they do it almost like a mammo image as well.
Yeah.
It's fantastic. So, and it can find things. It finds lots of benign things as well, but what we're really looking for are those things that cause distortion and spiculated masses, that kind of thing. And I think with using some AI techniques to provide a report could really transform ultrasound screening here in BC. So it's certainly something that radiologists are all looking at. And yeah, so that's got some promise because there's not enough text to do this.
So again,
and
text.
then there's some evidence, particularly coming out of Ontario, that so C's and D's, so A, B, C's and D's. So that's how we classify breast density. A meaning predominantly fat. B means scattered fibroglandular tissue. C is heterogeneously dense, so there's a little bit of fat in there. And D is extremely dense, where it's really difficult to see through. So there's some evidence saying that the C's would probably benefit a lot from this ABUS or breast ultrasound, and the D's, breast ultrasound and or MRI. And there's some evidence that the MRI is probably a little bit more superior to that. So ultimately, my passion would be that we have screening MRIs here in the province, to help those women with the 4s, the Ds, that get screening supplementary with that and mammography.
Amazing.
Yeah.
Well, we just have to keep talking then.
We need to find the breast cancers, particularly in the younger women that are more aggressive. We need to find all breast cancers. I'm not saying that, but we can't forget about the more aggressive breast cancers that often occur in younger women who have denser breasts, have young families, are working in the community. It's a significant loss to our community when they die of breast cancer. And we know we find more of them this way. No, we find more of them this way. So,
I want to talk a little bit about, you also specialize in prostate. I know nothing about those because I don't have any. But I'm sure there's a few of our listeners that do. So what can you tell me about screening? Like, is there a similar program for prostate screening?
Well, thank you for including men's health.
Yes,
thank you for including men's health.
Absolutely.
So, yes, I have like a breast and body fellowship and MSK fellowship. So one of the things when I moved here is tried to really help augment the prostate MRI program here. So there isn't a screening prostate MRI program, but prostate MRI has drastically changed the way we stage and identify prostate cancer in men. So in medical school, I think I was taught that, by the time a man's 60, there's a 60% chance he has prostate cancer. By the time he's 80, there's an 80% chance he's got prostate cancer. But what we need to find is the ones that are clinically significant. Oh, yeah, it's very high, but not all prostate cancer will ever cause death.
Oh,
we want to find we want to find the aggressive types of prostate cancer, what we call Gleason. So that's kind of the pathology, the pathologist term about, telling us how aggressive a prostate cancer is. We know that there's evidence in the prostate MRI research is that there are certain findings on the prostate MRI that can indicate that it's probably a more aggressive tumor. So prostate MRI finds them easier. Prostate is hard to image with ultrasound. That's conventionally the way we do it.
Right.
Or the urologist or the oncologist actually do a digital rectal exam and they feel the prostate for abnormalities, just like a breast exam. So, it was a little bit, I'm not putting anybody in medicine down, but, for a while, men's imaging of the prostate was a little bit archaic. We didn't have, we had ultrasound and what we call the DRE or digital rectal exam. And that was kind of it. And then, the radiologist or the urologist would do these ultrasound guided biopsies. Just, if you saw an abnormality, you'd go for it, but sometimes you don't see it. And we just do these random biopsies. So it's just radically changed the way we stage them and sometimes directs where we do the biopsies for the surgeons and the oncologists. So
is there any way, like, I don't want to disclose my husband's age, but I don't like that stat. Is there can men
What do they
examine? Like
What do they do?
Yeah, exactly.
So this is where their primary care provider is really important because they can do that digital rectal exam.
Got it.
There's something called the PSA, so prostate specific antigen, but it's notoriously it's sensitive, meaning we can find, we find elevated markers, the elevated marker, but it doesn't necessarily mean the man has a significant prostate cancer or even prostate cancer. It can be elevated for other reasons. So it's not specific.
Okay.
So it has limitations, and that's where the MRI can help, and the DRE, and then us doing a biopsy can help to see if there's inflammation or prostatitis of the prostate gland, which could end up being the reason for it. So they need to talk about it with their doctor.
Okay.
That's the basic gist
of it.
Would
they
is
feel something?
Sometimes they can.
Okay.
Absolutely.
Yeah.
But the man's prostate often hypertrophies, or means it gets bigger and it gets nodules, and they're benign nodules as they get older. It's one of the reasons why they have urinary frequency and can't empty their bladder as they get older, as many men can attest to. So that can make it a little bit difficult sometimes to find small cancers, or it can mimic a cancer.
I see. So the MRI technology is pretty valuable as a tool. Let's talk about MRI a little bit.
So when we brought it here, like our machine here in Kelowna is very old. It's more than 20 years old, and that's why you and I the whole foundation has become so close.
And I
because
think the community now knows it's like we hold the title for the oldest MRI in
we have
BC.
A dinosaur, and we're trying to do we're still a tertiary center, and we do a lot of high level imaging, along with Kamloops, and interior health. And they too had an old MRI that's been upgraded, but we've chosen to get 2 new MRIs, and with the help of we're going to get this 3T MRI. So currently what we do is, in order to get enough signal, because our machine is so old.
And overworked. It works, 147 hours a week?
Yeah, it's overworked, but it also doesn't have enough technologists. So this is another plug for anybody that wants to become an MRI technologist. There's lots of capacity for you to work in diagnostic imaging.
And they're all happy.
They're happy.
Yep.
They are happy in MRI. But this machine is, I'm going to talk about that after. So how we do it here at KGH is, because our machine is so old, we have to place an endorectal coil into the men's rectum. So we have 2 sources of signal. So MRIs are made...
All the men just cringed.
They do. Yeah, and they do.
I cringe for you.
So they basically get what we call a body coil that's wrapped around them, and then we place this endorectal coil in the rectum, which hugs the prostate. The prostate is like a walnut, and literally, for those of you that can see me online, the coil that's in the rectum sits up against the prostate, and then outside the patient's body is another coil, and that's how we get enough signal to find these cancers. The cancers turn up dark on some of the sequences, and can show some other findings that help us say, this is probably a cancer.
And that's with MRI.
Yeah. And then we can kind of grade it as to how significant we think it is, whether or not it's, a lower grade tumor or a higher grade tumor. So some people will come in and they've already got a diagnosed biopsy, diagnosed prostate cancer from biopsy, and then they come in to see, did we miss anything?
Yeah.
We know that we found this, but sometimes they're just, they're not blind biopsies, but we're doing very functional biopsies of the outer part of the prostate. So we don't see the inner part of the prostate well. So, the clinicians want to make sure we haven't missed something in the remaining of the prostate. So we do that. Men can have multiple foci, meaning multiple sites of cancer in the prostate. We also can see if it's extended beyond the prostate and is involving, the fat or, the nerve bundles that's around there, or even the bladder or the rectum behind it. So we can see lymph nodes and abnormal signal in the bone, if they have bone metastasis. So there's a lot of information we can get from them. So with the 1.5 old one, that's how we do this. The newer 1.5s are much better, and we can do it without an endorectal coil. But the gold, the what do we call it? The Porsche, I don't know, Lamborghini.
Gold standard.
Is the 3T.
Yeah.
And so they don't have to have the endorectal coil, and you can see much more detail.
Well, and I think broadly too, this current campaign that we're in, we are fundraising for the 3T. The province has approved replacing the 1.5T MRI. We desperately need that. But the addition of the 3T not only increases kind of like our ability in terms of what that machine can do, but also our capacity. Because, you know, anybody that needs an MRI knows it's a bit of a wait. So being able to increase the capacity that way is such a huge service, because kind of going back to the beginning of the conversation, like, it isn't just prostate. Like,
No, exactly.
MRI is so vital, or can be such a vital tool for so many things. Can you kind of just give like a high level, like what opportunities do we have by increasing our capacity to do MRIs in our community?
So having 2 machines that can do the imaging faster is probably in a quadruple amount of MRIs that we can do at KGH, which is unbelievable.
Yeah.
I will be very honest. The radiologists are a little bit scared of the volume and how we're going to deal with that, because we don't have enough
It's a people
radiologists
problem.
as well.
Yeah.
Again, it's the people problem. But what it's going to do, so it's not just prostate, it's not just breast MRI. We do a lot of neurological imaging. So we follow MS. We can follow treatment response with MS, so multiple sclerosis.
Mm-hmm.
Sometimes we're staging or following the treatment from brain tumors, facial tumors that can spread along the nerves and the deep spaces of the face and, you know, the skull base, where we can see those much better. Sometimes it's cardiac imaging, and cardiac health, heart health has massively changed in the last few years,
Mm-hmm.
and the guidelines for the use of cardiac MRI. Currently, we've got wait times that are 2 to 3 years for some people, and it's just not acceptable. So that will help us, you know, maximize the amount of patients that we can get caught up on those wait lists, and, you know, the appropriate people get the imaging.
Mm-hmm.
There's also orthopedic imaging, so sports imaging for the patients where it's appropriate. Like, not everybody needs an MRI. I will be very honest. Like, I'm also an MSK imager, and usually from, you know, an x-ray, we can tell if somebody needs, you know, a replacement, and the orthopedic surgeons don't want an MRI. They don't need one.
Mm-hmm.
But for some people that might have a locked knee, and they might have a meniscal
tear
tear
or
that's
something.
flipped,
Yeah.
or
Ooh.
something else that's causing a locked knee, is really important. Sometimes we are looking at the ligaments around a knee after, you know, some kind
An
of
injury.
trauma.
Yeah.
And it really helps the orthopedic surgeon figure out what he needs to repair, because down the road, that's going to help reduce the chance, or perhaps the degree of osteoarthritis that they develop, you know, years later afterwards. Sometimes it's the hip, and, you know, some young sports person has got a labral tear, or they've got, you know, just a congenital abnormality. And I don't want to say abnormality, I shouldn't say that, just a congenital variant that they were born with that predisposes them
Right.
to osteoarthritis and labral tears. And they can see these changes, and it can help them determine whether or not they're going to take them and repair their labrum, or, you know, shave off a bony spur. So seeing the labrum and saying, okay, this is a pristine labrum, I can go in, fix this up, and, you know, perhaps delay, or, you know, perhaps they will never get that osteoarthritis. And vascular imaging, nerve imaging, looking for tumors along the nerves. We can just,
like in the spine or whatever.
Yeah, coming out of the spine, the plexus that come out. It's unbelievable. Small joints, like I know this, because I love looking at fingers and whatnot. And it's right now, the images, I'll be very honest, they're very blurry.
Yeah.
But with the new techniques, the 3T, we're going to be able to see all of those small little structures, and it'll really help the plastic surgeons with their reconstructions. And
Amazing.
It's huge.
Yeah, amazing. And this community is generous, and we're getting there. So hopefully soon we'll be able to have the capacity that you and your teams need to be able to really amplify the care that our community needs. And again, these MRIs are all often kind of like the first step to, you know, a treatment care plan, right? So super important. Okay, I'm going to switch gears a little bit. I want to ask you a little bit more sort of on the personal side, because part of what I think our community can really benefit from is like knowing that there are people behind the doctor label. And you are one of the most, like I said, empathetic people. What makes you excited about the future of radiology?
Just what we can see and what we can do. Like,
that's such a great tagline, by the way. Like, really,
you got to write that down so I don't forget it.
Yeah.
But it is. The technology is improving so much, and the different techniques to help us. You see it, but can you figure out what it is? Different techniques that can help us identify whether something's normal variant or not worrisome versus something that we know we need to worry about. It could mean that somebody doesn't get a surgical procedure or a biopsy, right? So that's affecting patient care. And then what we can do. Like, it's incredible what our team does in the interventional suite, right? So
yes, we're having Dr. DeCarampe come on and talk about that.
So he will talk more about that. But it's just phenomenal what they can do.
Yeah.
And they're so excited about, the programs that they've started and what they're doing. It's, in some days I get really jealous. I'll be very honest. But
it's very sexy sweet.
Well, it is.
Yeah,
it's beautiful.
it is.
And they are making a big difference in patients' lives, like the stroke care that they're doing.
Yeah.
I personally had not here, but I had a family relative that had a big MCA embolus and they pulled it out. And, he's walking around today without a deficit because of that. And that's just life-changing. When I was a medical student, one of my very first patients on what we call CTU, and that's when you're on internal medicine, and it was a woman that had a large MCA, meaning middle cerebral artery stroke, and it's devastating, right? It brings you hemiparesis, and you can't move your arm, can't move your leg, and half the time you can't talk. It's hard to swallow. It is a life-changing event, and we literally had discussions with her and her family about whether or not we were going to provide any kind of supportive care. Because at that point, sometimes for those patients, it's like, do they want to pass or do they want to live on with this incredible, morbidity because of that event?
Yeah.
And I can't it was a life-changing thing as a medical student to see.
Yeah.
And to see what our team can do. Not every case is positive. There are difficult cases, but we're on that other side of where we used to be.
Every day there's more and more.
Yeah. So, we're treating bone tumors whereas before, somebody might have had, an osteotomy, meaning you cut out that section of bone and whatever. And they're treating liver cancers with different types of techniques rather than having to open up their belly and have big morbidity and hospital stay from that. It's life-changing.
It's amazing. We touched on this earlier, but I'm going to circle back to it. How do you emotionally, mentally, we talk a lot about bedside manner. How do you do it? You have to, I know you can't necessarily tell people, but and you have to break people's mortality bubble. How do you do it?
It's not the easiest thing.
Yeah.
I mean, telling somebody they've lost a baby or telling somebody that they've got cancer are probably the two most devastating things that people will hear, and that's often what a radiologist will do. So people might not know what a radiologist is, but when they get that diagnosis and see us, they really realize what we do. But it's not easy, and there are days you come home and you're just like, you hug your family closer, you go for a run, you try not to drink a bottle of wine.
Yeah. Yes.
Yeah, have a sip. But, it probably has led to, that's why there have been many physicians that have, I think that just recently in the last year, there's 2 physicians in Alberta that have committed suicide. The toll is not easy. But you have to find ways to deal with that stress. And often I cry with my patients.
Yeah,
You're like,
I know.
everybody knows that. I cry
Wear
at the
your heart
drop
on
of
your
a hat, and
sleeve.
that's fine. But I try to be as honest as I can with them, and give them as much information within, my limitations that I can, and giving them a plan. So, if I'm giving them bad news, often I'll talk to the physician, their primary care physician or their specialist before, and then, so they're not leaving, my office or hospital space not knowing what the next step is.
Yeah.
Sometimes they come in and they're getting a biopsy for something they have no idea, and I have to consent them. So sometimes I'm actually the first person telling them, like, no, there's actually something in your liver that's worrisome, and that's why I'm doing this biopsy. So that's the other situation that sometimes that happens.
How do you, this podcast is I'm like really up close to my mic. So interesting, Brenda. Our podcast is called The Wealthy Podcast, and really what we're hoping to do is really have these conversations to inspire people to really consider the breadth of what health is, and that, being wealthy truly is...
Health is wealth.
Health is wealth, yeah. And so I'm going to ask you, I follow you on social media. I know that you are a very spiritual person, and that is obviously one area of health, mental health, emotional health, community health, physical health. What areas of your life do you feel you are wealthy or abundant in?
I have the most amazing husband, that's for sure. And I was fortunate enough to adopt a child, and those two are the best things in life. I have 2 dogs that no matter what, they love you. So they're just the most amazing things.
What is it about pets? Hey,
yeah, animals are amazing. Exercise, I find activity is one of the biggest things that gives me my mental health break, and that hasn't been easy to get lately. Since the pandemic, and medical imaging has been very stressed because of, our population has grown, right? A lot of people moved to BC during the pandemic and thereafter. So that has changed. There's more demand. I think the practice of medicine has changed. They're using diagnostics more, is what I mean. Because people don't have that access one-on-one sometimes to a primary care provider as well, and they're using telehealth, and that still can at least get people in the system, right? So it has its place, but there's more imaging happening, and so there's not enough of us.
No time
and
for
the time
going for a run.
Oh, the time worked is it's incredible. I've never worked as hard as what I am now, and that has been forcing me to take a look at my life and my work style, and make some changes to focus on that, and to focus on my physical well-being, because I'm not running as much and whatnot. So that's, healthcare practitioners all have to do that so that we can provide for our patients, and because otherwise we're just not there for them.
And I think, your I don't know, profession, if you want to call it, has a bit of an uphill battle there, because you've been conditioned to work really stupid hours and shift work, and there's some sort of I don't know if it's a badge of honor to be able to just push through. And I think now
you work with broken bones.
Yeah.
I had a sprained UCL, which means the ulnar collateral ligament, so a ski pole thumb, and I still did biopsies with a splint on my hand. Because there's nobody else usually to replace you except for your other team members to pick up the work, and so you just feel this sense of duty to the rest of your team that you don't want to let them go. So radiology is lucky since the pandemic as well, though we're able to have some remote reporting stations, which allows us to sit in the background and read, which is unique to radiology, right? Not all clinicians can do that, where others can do the hands-on image-guided procedures and whatnot. But I've worked with my leg on, one of those little wheelies when I sprained my ankle and wheeled around the hospital. And
okay, so we're going to be better in that area.
Oh, yeah, and I know other physicians, even one right now that I work with that probably shouldn't be working but is, and, because of an injury. Yeah, but
we're all learning.
Yeah. Yeah.
How to balance our wealth.
Yes.
My last question for you. This has been such an awesome conversation. What is a meditation or an intention that you are working on in your life right now, either personally or professionally?
So I think it's to take a deep breath in and know that you can't solve it all right now, but keep moving forward. So this perpetual forward motion is kind of my mantra that my husband and I have. Perpetual forward motion. So it may not ever be as fast as you want it to be, but just keep moving forward. So in the vision of medical imaging in the province, in my vision of my life, in the vision of our department, I just want to keep things going forward. So
amazing. Well, Dr. Brenda Farnquist, this conversation was long overdue. I'm so happy you joined us, and thank you so much.
Thank you for having me. My pleasure.